So, hello, I'm Andrew Conway Morris. I'm an intensivist from Cambridge and an academic. And I'm going to talk about how we diagnose pneumonia. And I think follows on quite nicely from Dan's talk. We did coordinate a little bit, but not too much. So I think that's worked out quite well. So the first question I want to address is sort of slightly wider than what is pneumonia, but what's a diagnosis? And then perhaps talk about what is pneumonia. How can we diagnose pneumonia? And then at the end, talk a little bit about how we actually diagnose pneumonia. And I have to say, this is in ICU. So that's my area of expertise. And I apologize to those of you who are not interested in what we do in ICU. But there you go. So what is a diagnosis? So ultimately, as physicians, we're sort of questing for the truth. That's this sort of slightly cheesy picture here at the bottom. I haven't put the heroic slogan across the bottom, but we're looking to identify a sort of pathological entity, a disease, if you like, with some degree of certainty. But in order to get there, what we have to do is integrate lots of different bits of data. So, we're putting together some clinical examination, maybe some tests of various different sorts, and trying to sort of find our way through this misty pathway to try and achieve this degree of enlightenment. And of course, the problem is that our tests are all imperfect. So if we had a perfect test with 100% sensitivity and 100% specificity, then it wouldn't matter what the patient was doing when they first came in, because we'd do the test and we'd know for certain what was going on. But none of our tests are that good. So we have to consider, how likely is it that this patient has the disease I'm testing for? And then how good is my test? And then try and integrate that together to sort of approach our, where we're getting to. So to take this example here, this is a patient who comes in with a probability of having the disease of interest, let's say pneumonia, of about 10%. And we've got a reasonably well-performing test. So the black line is our positive likelihood ratio. So if it's positive, then after having done that, the chance of having the disease is about 70%. So 7 out of 10 times you'd get the diagnosis right. If it's negative, the chance of having the disease is actually pretty low. But of course, this is crucially impacted by how likely it is they've got the pneumonia in the first place. Yeah? So you've got to think about what's going on with this patient. And of course, nobody arrives as a blank slate. Yeah? Everyone comes in with a history, with a little bit of examination and so forth. So you're sort of building that picture as you go along, but just thinking about each of those things. Now, of course, a diagnosis, therefore, you can obviously move along this kind of certainty gradient. So no one starts at zero because they're in hospital or they're in their GP practice or something. They've presented to us as clinicians for a reason. But essentially, we can have a kind of low certainty through to a sort of absolute certainty. But diagnosis isn't a kind of intellectual exercise. It's there for a purpose, and the purpose is for us to inform treatment. And when we decide to shift from making that diagnosis to treating, is dependent not only on how certain we are in the diagnosis, but also what's going on with the patient. So, a lot of us exist with patients at this sort of end of the spectrum. Yes, we're dealing with acutely unwell patients who have a high risk of deterioration. And at that stage, we probably just want to intervene. We're not going to worry too much about what the diagnosis is, because if we hang along too long to find out and be certain, they're already dead. Equally, there are conditions at the other end of the spectrum where they're not going to kill you that fast, and we probably want to be completely certain about whether they have that. And then, of course, playing into this is our treatment risk-benefit. So clearly, a treatment that is high risk, we want to be pretty certain we're treating the right thing before we expose a patient to it. Whereas a treatment that's low risk, well, perhaps we can just sort of throw it around like Smarties. And so we sort of integrate this into a kind of matrix. So high-risk treatments in a patient who is at pretty high risk, but we still want to have a high degree of certainty. Whereas if you've got low-risk treatments, and one might argue that antibiotics are a relatively low-risk intervention, I think that could be debated, but, we might just sort of give that a bit earlier. Obviously, what we'd like to do is to move ourselves along that certainty gradient faster than we currently do in order to make more accurate treatments. So let's get on to what I've actually asked to talk about, which is pneumonia. So as Dan has kind of already mentioned, pneumonia is alveolar inflammation, and if we talk about infectious pneumonia, alveolar inflammation triggered by an infectious organism. Okay, that's its fundamental nature. And that is fundamentally a histopathological diagnosis to make. That's how you achieve your true gold standard. Now, I don't know about what goes on in your hospitals, but certainly in mine, that almost never happens. Yeah, we never biopsy our patients, certainly the ones who are on ventilators. So, for very good reason. So what we need to do is kind of build up a proxy measure. So we can use clinical criteria, so something that suggests a respiratory focus. We can use radiological criteria, be that CT or chest X-ray or ultrasound, to identify alveolar inflammation or infiltration. And of course, we then want to know that there's something infectious or inflammatory going on. So we've got a variety of laboratory-based tests that we can use, be they peripheral blood or experimentally alveolar markers. And of course, microbiology, because in the end, this is triggered by an infectious organism. That's kind of important. And so we combine all of these together to give us a sort of proxy measure for what we're seeking. So we're perhaps not at the pinnacle of diagnostic enlightenment, but we're pretty close to it. Are we? Well, that's the idea. So now this is data that there's an obvious error in here because I've got my sensitivity and specificity the wrong way around. I noticed that on the train this morning, so I apologize. But this is focusing on ICU. In ICU, your clinical findings of pneumonia, so to speak, are pretty rubbish. Okay, they're very sensitive, but they're so non-specific as to be almost useless. And that's actually just for predicting radiographic infiltrates, let alone pneumonia itself. Radiological, so patients who have, this is chest X-ray, I've illustrated it with a CT just to be annoying, but it's chest X-ray evidence of infiltration in ICU. Only 40% of them go on to have a confirmed pneumonia, so 60% don't. So again, it's pretty sensitive, but it's not very specific. We look at laboratory measures of inflammation. Again, these are all pretty non-specific because they go up in all sorts of things. And again, in my patients in ICU, go up for all sorts of reasons, not always infectious reasons. So we've got a collection of non-specific pointers towards pneumonia. And really, to make a final diagnosis, we want to have microbiological confirmation. And that can be done in a number of different ways. Now, I'm not going to get into the debate about endotracheal aspirates versus bronchoalveolar lavage because most of you aren't intensivists and you'll all go to sleep very, very rapidly. Essentially to say that once again there we're largely trading off sensitivity against specificity. So bronchoalveolar lavage, probably more specific, you lose a bit of sensitivity, endotracheal aspirate the other way. Now, having said that we need microbiological sort of confirmation to make our diagnosis, this is the problem, okay? Apologies to microbiologists in the audience. So here we are taking our sample from our patient, in this case, ventilated patient in ICU. Okay, so we take it, and this is when I'd like an answer, to be moving along my certainty gradient, okay, 1 to 4 hours after I've taken my sample, as I'm trying to make my clinical decision about what to do. And of course, as we all know, this is where we tend to end up. 48 to 72 hours later, some of the time, we get an answer. And again, Dan's shown the study from the States. In community-acquired pneumonia, 60% of patients in there have no identified organism. Some of them probably haven't got community-acquired pneumonia, but a lot of them will do. We're just not very good at picking them up. Now, I think I'm not going to talk too much about the exciting new world of molecular diagnostics today because that's what the rest of the day is largely about. I'm hoping this slide is going to come out of date in the next couple of years. So that's how we can make a diagnosis of pneumonia in ICU. Those are the criteria that we should use. What do clinicians do in reality? So this is a study that we did now nearly a decade ago. Just ICU consultants, just in the UK. Not a particularly stunning response rate, but there you go. And it focused on one particular form of pneumonia. And again, Dan's already undermined that as a concept, but there you go. So we've focused on ventilator-associated pneumonia. Everyone in the study said, yes, we should get microbiological samples. They were a little bit sort of divergence on which sample they got and whether they strictly took them before or after antibiotics. A third of people didn't even use a chest X-ray to make a diagnosis of ventilator-associated pneumonia. So kind of reflecting back, it's not just patients, clinicians at the front door who are not necessarily doing it. It's all the way through. So we've recently, this study is actually ongoing, but I've got some preliminary data from it today. Trying to repeat this study, but in a global audience. So being distributed by a variety of intensive care societies across the world, and as of yesterday, ANZACS is doing it as well, which is nice. And we expanded it from VAP to the other forms of pneumonia that one might encounter in ICU. And I say it's closed today. Actually, we're going to run it for another couple of weeks because the Australians have very kindly got on board. But this is some preliminary results out of back end of last week. So we've got 1,200 responses, and this is where they're coming from. So across the world, significant representation from two very two very high population countries in South America and in Asia. And it's across a range of income spectrums. So it's not just high income countries. We've got middle income and a small response from low income countries, which also have a relatively low coverage of intensive cares as well. And what we asked was, what do you use to diagnose pneumonia? So almost everyone is using clinical criteria. That's in blue whether they're routinely using it, so that's always or sometimes or mostly. And most of the clinicians think that having some sort of clinical criteria is important, is essential for the diagnosis of pneumonia. When we look at radiological examination, this is in ICU, almost everyone is doing chest x-rays, but about a third of people think that actually it's not essential to have chest x-ray infiltrates to prove alveolar infiltration. And that's not because everyone's using ultrasound. So ultrasound is not all that massively well used, and certainly people who think it's essential doesn't make up that difference. So clearly clinicians across the world are actually not that different from clinicians in the UK 10 years ago in thinking that radiological criteria are essential. When we look at which microbiological tests they do, again, endotracheal aspirate or sputum is the commonest, and then a mixture of bowels and mini bowels. Patients who are not ventilated obviously have a much lower rate of bronchoscopy, and that's not a huge surprise. And you can see perhaps a slight increase in the rate of microbiological sampling in the HAP and VAP. I think that's probably, we didn't ask in the thing, but I think it's probably just because of ease of availability. It's much easier to take a sample from a patient who's on a ventilator than it is from someone who isn't. Now, if we have a look, so almost everybody here says they take microbiological samples. If we look at the small minority of clinicians who say they're not taking microbiological samples, you can see a really strong income gradient, okay? So looking at, in community-acquired pneumonia, around half of all clinicians, and it's a small sample, but in low-income countries, are not taking microbiological samples. And clearly there's a gradient there. And I think this accounts for, this is due to lack of availability of resources. If you haven't got a microbiology lab to send your samples to, there is no point in taking them. If we have a look at molecular diagnostics that are used, and I've sort of classified these reasonably broadly, this is a finding that actually surprised me. I didn't think it was going to be this prevalent, but you can see here, urinary antigens, reasonably commonly used, Legionella more than Streptococcus, singleplex PCR, about half of them. Multiplex PCR is available to 80% of people responding to our things, which seems really quite remarkable. And you think, okay, goodness me. And these are the tests that they say they do. So the commonest thing is I don't know what test they use, which to be honest, I know what tests we're using for respiratory bugs in my hospital, but I couldn't tell you what we're using for CRP. So it's not a huge surprise that clinicians don't know what they're using, but these are the tests that they report having available. Now, we've mentioned income gradient already. This is what you have a look at non-availability of tests. So you can see that yes, these tests are available, but most of them are being made up by clinicians who are operating in either high-income settings or upper-middle income settings. When you're getting into low-income settings, they become much, much less available. And of course, there's a big difference between having a test available and actually being able to use it. So when you ask clinicians, what are the barriers to use? Well, there it is, cost, single biggest cause, availability of reagents, availability of expertise. And again, if you look at the barriers that are there, again, there's a strong income gradient. So, just under 50% of those in high-income countries say there are barriers. Everyone who operates in a low-income country says there are barriers to the use of these. So, in conclusion, diagnosis is a probabilistic approach to trying to work out what is going on with your patient, and you need to understand your test criteria, and tests are a broad range of things from clinical examination through to laboratory tests, and think about what is the probability my patient has the disease of interest before I do my test. Pneumonia strictly speaking, requires evidence of alveolar infiltration. And that's almost always proxy measures because we're not going to get biopsies for them. The growth of more sensitive and rapid microbiology will require careful attention to pretest probability. So the more sensitive we are doesn't mean we can make a diagnosis purely on the basis of that. We still need to think about our patients and patient selection. Yeah? So again, in my world, a lot of my patients are colonized with gram-negatives within 24 to 48 hours of being intubated. Okay? If we take off samples from them willy-nilly, we will have an awful lot of false positives. However, I think there are real sort of potentials for these tests because they will shift us along that confidence gradient. So that will allow greater confidence in our treatment or possibly withholding treatment in patients who we don't think have infectious pneumonia at an earlier stage of the disease. Clinicians' approaches to the diagnosis of CAP, HAP, and VAP are very similar, perhaps speaking a bit to what Dan's already said, that actually we recognise that there's a clinical syndrome of pneumonia and where it arises is slightly less important than the fact they have pneumonia. Almost everyone in ICU is sampling microbiologically, although there is an income gradient present. Molecular diagnostics seem to be increasingly widespread. Now, of course, this is a self-selecting survey, disproportionate. I can show the contributors and so forth, disproportionately from teaching hospitals and so forth, because that's the nature of the networks through which it gets spread. But although they're increasingly available, and far more available than I expected to see, there are significant barriers, and the areas in the world that have the greatest burden of antimicrobial resistance and suffer the greatest from it have the least access to the tools needed to treat it. So just to say thank you to all of the people who had been involved in the DPRISM survey. That's them there. And yeah, we can discuss this further.
Thank you very much. So who's going to discuss or take a pop at Andrew? Vicky.
I had a question about the PCR uptake, because I was surprised it was that high, but did you distinguish between PCRs like the pneumonia panel or the curetes that can pick up bacterial pathogens, which are obviously important, and those that only pick up viral pathogens? And for example, when they answered FilmArray, did they mean the pneumonia panel or the respiratory panel?
So we didn't distinguish. I'll just come back to that slide. So we didn't. We just said, broadly, which one are you using? And as you can see, the only one on there that's definitely got bacterial pathogens on it is the curetis panel. There's a variety of other ones there, and most of them. I suspect the answer is that most people are using a viral plus minus a couple of atypicals. And that's the more widespread one rather than the pneumonia panel, especially given the cost issues that other groups have already raised. And the aim of this study wasn't really to get into which molecular diagnostic they were using. It was sort of a part of the broader question. But yes, no, I agree. I mean, I have to say I was slightly surprised how infrequent the singleplex PCRs were reported, because I think actually, every hospital in the UK right now, you could do, a SARS-CoV-2 PCR. Pretty much, yeah. You've got it available. Yes, it may be, and this is always a problem with surveys, It's,
So they can't amend the pneumonia panel because it was only launched 2 years ago, 3 years ago?
Well, I mean, this is results from 2022, so...
Oh, right, I thought you said it was...
So the previous one, so in the previous study that we did was just in the UK, that was in 2013. That's before most hospitals had even heard of the term molecular diagnostics, to be honest. It was the odd thing for flu and so forth. But yeah, no, this is bang up to date.
And were there lots of US sites in this?
No, so it's about 60 sites in the US. I'll see if I can find that slide. Okay. Yeah, there you are. So I mean, the US is a significant contributor to it, but certainly not the dominant. And actually, even Western Europe, which because it was originally distributed through the European Society of Intensive Care Medicine, I kind of assumed that it was going to be mostly European respondents. In fact, it's not.
So it's Brazil and China.
Are the two largest responses. They make up about 10% of all responses each. So about 20% have come from those two countries.
That suggests a whole bunch of different stuff lies under the bonnet to your results.
Oh, absolutely.
Because I don't think any of us, I saw a lot of collective eyebrows getting raised at who's doing a singleplex now? Yeah. And if you're telling me this is new data, they're clearly in another world doing something else. I'm going to ask, I was really interested in your high-income country barriers to molecular thing, and I'd just like to ask for a straw poll here. Hands up those of you who either have been involved in or have heard of and know and are aware of this point. And the point is, I want to do some molecular stuff that I haven't got yet in my unit as a clinician, in my department as a microbiologist. I want to do this extra molecular test. And somebody comes to you and says, you got to justify the cost. Is that all? So the rest of you can get these tests? No. So I mean, the point is, isn't it interesting? High-income countries, it is still considered in your survey a really important barrier.
Yeah.
And I don't know whether we're going to talk about this, but we've been doing the money piece on, within our trial, and it seems to be interesting that the test, the film array arm, in terms of total ICU cost, was inferior to the control arm. And actually, we're digging around that, but the bottom line is that the health economics people who do this for a living say, come on, guys, ICU is really expensive and it's buried in it. But yet, for most of us trying to get a new test in, you've got to jump through so many hoops of flame. And they say, well, you're going to have to save it somewhere else, or you're going to have to stop another test, which probably isn't the right way to go, really, if we can do better medicine. Any other questions? Sorry, I'm ranting.
No, can I just comment on that? Because I think you're right that those barriers are definitely there, and certainly organisationally we can experience those. What's interesting, I think, when you watch a group of clinicians get hold of these tests, though, of various different forms, it doesn't really matter which one we're talking about, is the enthusiasm with which they are adopted. Because suddenly it's like having the blindfold taken off, and you go, now I know what I'm dealing with. And obviously people tend to remember the spectacular, that was a bug I didn't think of, or that was the thing there. But actually it's wider than that, and that doesn't get captured in health economic analysis.
That's right, and I really hope we can have a discussion about this later. The perceived value of knowing the bug a bit quicker, or knowing the antibiotic is whatever it is, but in my experience, clinicians run on the I remember a case of thing, and this is a huge positive recall bias. And without a doubt, if you got a test that out of the blue says, you didn't even realize your patient's got flu A, and we'll go, that is a hugely valuable thing for clinicians. And it's almost intangible, isn't it? That so you have the film, whatever, you have a molecular platform, and it does a bit better, but from time to time, it does infinitely better because it finds something you never would have found otherwise. How do you capture the value of that? It's kind of a difficult one, isn't it? Thank you very much.
No trouble at all.
Thank you.
Thank you.